A very good morning to everyone. I am Dr. Kaustav Basu Thakur, MD Physical Medicine and Rehabilitation. I am Associate Rehab Physician and Consultant at Rihavana Care, Salt Lake, Kolkata. The main focus of today's video is to answer some queries and questions that usually come in our Facebook page, YouTube channel as well as our own website regarding stroke rehabilitation. So our first question has been asked by Mr. Jagdish Singh in our Facebook page that what is stroke and what are the problems faced by a patient post stroke. So stroke is a medical emergency. So what happens in stroke is that there is sudden stoppage of blood to particular area of the brain or bleeding into particular area of the brain without any actual injury or trauma to the head. So what happens is that due to the sudden stoppage of blood or due to the bleeding in some of the areas, the cells which are there or the nerve cells which are there in those areas of the brain die. So because of that, these cells which perform different functions of the body, they are unable to perform those functions. So coming to the second question asked by Mr. Jagdish, that what are the problems faced by a patient post stroke. First we need to understand the various functional areas of the brain that might get affected by stroke. So the complications or the problems will depend on which functional area of the brain is affected. So if you look at this picture, so this is our brain and it has been divided into the different functional areas. So this red area is the anterior-most, the front part is responsible for our cognition, behavior, memory. So any stroke affecting this area will lead to problems regarding these functions. The next area is known as the motor area, which usually is responsible for the movements of our different body parts, our limbs, our legs, arms, our body. So any stroke that affects this area will lead to paralysis, weakness of all the muscles and all those. The area just behind the motor area is known as the sensory area. So sensory area is responsible for the different sensations we feel regularly, like touch, then pain, then temperature. So any stroke that affects this area will have so many sensory problems, like different understanding of all the sensations. The posterior most area is responsible for our vision. So any stroke that affects the posterior most part will affect the vision of the patient in different ways. Then we have this lower most part that is responsible for the gait and balance of the patient. So any stroke that hampers or disturbs this area will lead to difficulty, balance difficulty, as well as, so once there is balance difficulty, there will be problem in walking, in standing balance, everything. The last area is this area which is responsible for the speech, what we are speaking, that speech area. So when one is affected by stroke that affects this area, will have difficulty in speaking or speech problems. So rehabilitation does not mean only physiotherapy. It also includes occupational therapy. It includes speech and swallowing therapy and language therapy. Then medications for speech or loss of motor power, then improving the spasticity or muscle tightness, as well as some interventions or injections that might be required. The next question has been asked by Mr. Deboboto Bishas in our mail ID, that what is the difference between rehabilitation and physiotherapy. So I think I have answered pretty well what is the difference in my last query asked by Mr. Kaushik Goswami, that what is the difference between rehab and physiotherapy, that it is only a part of the entire rehabilitation program, and rehabilitation does not mean physiotherapy. The next question asked by Mrs. Arati Chaudhuri in our YouTube channel, that what are the complications of stroke for which rehabilitation is needed. See, the complications of stroke they depend on many factors, like where is the location of the stroke in the brain, then what is the size of the stroke, then whether treatment was started early or whether there was delay in starting the treatment for stroke. So all these complications will depend on all these factors. So one of the most important complication we see is paralysis. Most of the people see that patient is paralyzed one side in stroke, but I want to tell you that paralysis or weakness of the limbs is only the tip of the iceberg which we see. The huge number of complications are unseen, like the lower part of the iceberg which remains hidden. So one of the most important complications is difficulty in performing the day-to-day activities like eating, like grooming, dressing, then taking a bath, toileting. So many these ADLs are affected. Then one of the more important complications that many patients complain is that of a shoulder pain following stroke. So there are many causes of this shoulder pain, that it might be due to the subluxation, it might be due to adhesive capsulitis, bicipital tendonitis, subacromial bursitis. There are many causes. Then another complication is which may be seen in many patients, they usually recover by the end of 1 month, is that of neurogenic, inability to control bladder as well as bowel. Then another complication is that of pressure sore or a pressure injury or a bed sore in common terms. Another very important complication in a stroke patient is spasticity or muscle tightness, that might lead to several other complications like heterotopic ossification, difficulty in walking, difficulty in balance. So we must treat all of the complications separately and must understand that stroke is not paralysis only. So once the patient is medically stable post stroke, the patient is directly shifted to our neuro rehab center, Rihavana. At first the patient enters the OPD through a complete barrier free environment to attend the rehab physician or a PMR specialist who examines the patient thoroughly neurologically and identifies the different issues and problems affecting the patient. Then the long and short term goals are set and the entire comprehensive rehabilitation program is planned out. See, at Rihavana, the entire rehabilitation program is carried out by a team, our rehabilitation team, which consists of rehab physician, physical therapists, occupational therapists, speech and language therapist, and especially rehab nurses. So we have, what we do differently at Rehabana is that we have divided the therapy sessions or into different stations. The entire area which is known as the rehab prime has been divided into many stations. Like first is rehab relief, where all the interventions are done, like any injections of botulinum toxin, any intra-articular steroid injections for shoulder pain, along with dressing for pressure injury, pressure ulcer. So all those are done by the rehab physicians at the station of rehab relief. The next station is our rehab care, where transfer training, toilet training, all these are taught, along with bed mobility training, and most importantly wheelchair training is done at our rehab care. Following rehab care, we have the next station of rehab digital, where all the VR technology along with the functional electrical stimulation, then other electrotherapy, then other paraffin wax bath, all those equipments are available. And finally we have our rehab rejuvenex, which involves our healing garden or the horticulture therapy, which improves where the patient can take up as a hobby of doing plantations every day, improve the motor fine motor functions of their hands, and have a good pastime during their stay at Rihavana. Next station is rehab power, where the physical therapist is usually performing the strengthening of the weak muscles, stretching of the tight muscles, neurodevelopmental techniques, then bed mobility techniques. All these are performed at the station of rehab power. Following rehab power, we have the rehab motion, where the mobility of the patient is usually improved by using cycling or any unweighted treadmill, then balance training. All these are done in rehab motion. Then the next station is the rehab touch, where that station is mainly manned by our occupational therapy. The role of the occupational therapist is to assess the activities of daily living, what the patient is unable to perform the day-to-day activities, and the ADL training. Along with that, sensory motor retraining and fine motor retraining, all those are done by the occupational therapist. So I think I have cleared many doubts, answered many questions you have asked. Our page is always open, our center is always open for your any queries, any doubts, any questions. You can post in our Facebook page, YouTube channel, as well as you can mail us your thoughts, your questions, your queries. So that's it from my side for today. Stay fit, stay well. Thank you.